Hello, everyone, and welcome to Sarcoma Foundation of America's Subtype Series education session and discussion of PEComa, sponsored by Addy Bioscience. My name's Christy Urishton, and I'm the Program Manager for Engagement and Research at SFA, and I'll be serving as your host and moderator for this panel discussion. We thank you for taking the time to join us for this important conversation. Before we begin, I'd like to briefly go over the format and logistical details of this webinar. We have two panelists who are experts in the care of people with PEComa from two sarcoma centers here in the United States and abroad. Also joining us is a sarcoma patient sharing her experience navigating life with PEComa. Following an introduction by Michelle, we will open up to a panel discussion. At any time during today's session, you can submit your questions by entering them in the question and answer field at the bottom of your screen. I will then share your questions with our panelists. Please do not use the chat function to submit your questions. Please remember our panelists will not be able to answer questions related to your specific medical situation, so make sure that they're related to the topics raised during the session. Information in this webinar is for educational and informational purposes only and is not a substitute for medical advice from your physician. Today's session is being recorded and a link will be distributed to all registrants and posted to SFA's website. Finally, as a reminder, all participants are muted. Now, I'd like to briefly introduce our panel members. Dr. Wagner is the Associate Chief Medical Officer and Medical Director of Adult Ambulatory Oncology at Dana-Farber Cancer Institute, where he's also a senior physician in the Center for Sarcoma and Bone Oncology. He's an Associate Professor of Medicine at Harvard Medical School. His research identifies critical pathways necessary for sarcomas to form and survive, and he develops novel therapeutics to test both preclinically and in early clinical trials. Dr. Napolitano works as a medical oncologist in the sarcoma unit of the Royal Marsden NHS Foundation Trust. He is heavily involved in translational and clinical research in soft tissue sarcoma, including PEComas, GIST, and desmoid fibromatosis. He's been a sub-investigator in several phase 2 and 3 clinical trials and has co-authored over 50 peer-reviewed articles. Both Dr. Wagner and Dr. Napolitano are active members of multiple national and international sarcoma organizations. Michelle is a PEComa survivor, therapist, and active member of the Massachusetts sarcoma community, including the Race to Cure Sarcoma in Boston. She joins us today to share her experience. Thank you all for being a part of this discussion. Michelle, I'd like to hand it off to you to get us started.
Thank you. My name is Michelle Cormier. And I am a sarcoma patient. I was originally diagnosed in 2015 with uterine fibroids. At that time, it was diagnosed as PEComa, unknown malignant potential. And in 2023, I was doing a kidney evaluation for a family member. And as I got through the evaluation process, at the end, a chest x-ray was performed and multiple masses were found in my lungs. And at that point, I had further testing and was diagnosed with malignant PEComa as it had spread to the lungs. So it was definitely a surprise. I did not have any symptoms with this disease, typical to what other people experience, shortness of breath, rapid weight loss, and, all of that. No symptoms for me. And, it was a shock. I was able to, I'm very lucky. Massachusetts has wonderful care. And I saw a sarcoma specialist in my hometown, Worcester, Mass. And then I was able to see Dr. Wagner actually in Boston as, a PEComa specialist. And it was reassuring because he actually was he did the research study on the medication that I'm currently receiving, which is great. And I always take copious notes when I go to any appointment. I like to keep up with PEComa research, sarcoma research, and, you know, I'm excited to see what everybody has to say. I think that's it for me. I mean, you know, the usual dealing with insurance, the emotional stuff as you begin a journey with cancer. I mean, it's not pleasant, and it was, you know, a very big surprise. So I'm really eager to hear the current state of PEComa. Thank you.
Thanks, Michelle. It's really great to hear your story and hear how you were fortunate to end up at a sarcoma center and get great care. Not every person gets to have that experience. So I'm going to go ahead and pass it over to Dr. Wagner now, excuse me, and I'll pull up your slides. Give me just one second.
Thank you, Christy, and nice to see you, Michelle, and Andrea, good to see you too. I'm really glad to join all of you today. I'm going to talk a little bit about what PEComas are, and Dr. Napolitano is going to talk about how we treat them in more detail. I'll provide some background here. So what are PEComas? So first, let me back up a step and talk about sarcomas. And sarcomas are a family of rare cancers. They constitute just about 1% of cancers in adults. So that little blue wedge in the lighter blue circle there would represent about 1% of all cancers, which makes about 15,000 people in the United States diagnosed with a sarcoma each year. And that's compared to maybe over 300,000 patients diagnosed with lung cancer in the United States each year. And to make it even more complicated, there are about 100 different types of sarcomas. So each of those rare cancers as an entity as sarcoma, each one is even more rare when you break them down into 100 different subtypes. One of those subtypes is PEComa. And so if you take that circle and make it smaller, doesn't seem to be advancing. Christy, do you want to take control? And maybe can you take it back? And go to the next slide. Thank you. So PEComas are probably about 1% of sarcomas. So makes them super rare, or ultra rare is what we call them. And we estimate there's probably in the order of 1 to 200 people diagnosed with a PEComa in the United States each year. And it fits in this category that we think about for these sarcomas that we call ultra rare sarcomas, where there's fewer than one person per million people diagnosed with this per year. So Michelle, you're 1 in a million. These are rare tumors. Go ahead to the next slide. So what is a PEC? So an oma means a swelling of some sort. A PEComa is not what Arnold Schwarzenegger has on his chest with large pecs. So it's not at all that. So go to the next slide. A PEC is actually a perivascular epithelioid cell. And this is a term that was coined in the 1990s by some Italian pathologists. And their description was of an unusual cell type that had immunoreactivity. These are the protein stains they do in the pathology lab, with melanocytic markers, and melanocytes are the cells that normally make pigment in our body, and exhibit an epithelioid appearance, which is describing the shape of the cell, certain features to the cytoplasm, and a perivascular distribution, which means that they border on blood vessels, on small blood vessels. So that's where the name came from. It borders on small blood vessels, perivascular, it's epithelioid in shape, and it's a cell that's making up a tumor. So that's where PEComa gets its name. But what's interesting is that these cells are also present in other disorders, non-cancerous disorders, one called lymphangiomyomatosis, and the other one called angiomyolipoma, or LAM and AML. And just to avoid confusion, there's a completely different type of thing called AML, which is a type of blood cancer, a type of leukemia. This is specifically referring to angiomyolipoma. And go to the next slide, please. So these tumors and a few other rare tumor types make up a family of tumors that we call the PEComa family. And so they include things like angiomyolipoma, lymphangiomyomatosis, and PEComas. But as you can maybe make out in these pictures, these are the microscope slides. They have very similar appearance under the microscope, and these are all very similar cells. Again, the shape of the cell, which is sort of roundish, that kind of light pink haze to it with some white, that's the clear to granular eosinophilic cytoplasm. Those sort of lines that are going around in there, those are the blood vessels, those thin lines. And so you can see how the cells are kind of clustered around some of those small blood vessels. I didn't show it here, but PEComas typically will have expression of both proteins that are usually expressed in pigment-producing cells and melanocytes, and in cells, proteins expressed in our smooth muscle cells, our involuntary muscles in the body, like the bladder, the uterus, muscles that help our intestines contract. So those are smooth muscle markers. So most PEComas will express both melanocytic markers and smooth muscle markers. And there's no known normal cellular counterpart. So as opposed to a lung cancer, lung carcinoma coming from a particular type of lung cell, there's no normal PEC cell that these cells are known to come from. So we don't really understand where they come from, but they can arise anywhere in the body. If you go to the next slide, please. Now, the Bonetti and his colleagues also described this really interesting comment back in the early 1990s, which is that these cells that were apparent in tumors that characterized a syndrome that people can have called tuberous sclerosis complex, where they form different tumors in different parts of their bodies. And they can, including angiomyolipoma of the kidney, LAM of the lung, and cardiac tumors, heart tumors called cardiac rhabdomyoma. So they suggested even back then that maybe there was a genetic alteration that was common in these different tumor types, and that this could be the basis for the development of these lesions. And this is the syndrome that I mentioned called tuberous sclerosis complex, or tuberous sclerosis. It's what we call an autosomal dominant disorder, meaning that it just takes a mutation in one gene to cause this syndrome that people can have. And those genes were identified in the early 2000s as being either a gene called tuberous sclerosis complex 1, TSC1, or another gene called TSC2. And I'll show you in a second, but these two genes help, normally they function by suppressing a pathway called the mTOR signaling pathway. And if either one of those is mutated, then the mTOR signaling pathway is overactivated. And patients who have tuberous sclerosis complex have growths on many different parts of their body because all of their cells in their body have a mutation in one of these genes, and then sporadically the cells can develop a mutation in the second copy, and that leads to abnormal cell growth. So that picture of the face are these growths that can occur in a face. There's on the picture on the bottom, that's a brain, and so there are brain tumors that can form. On the upper right, that's a kidney, and that's a big angiomyolipoma coming off the bottom of the kidney. In the bottom right, that's a lung, and those darker circles in the lung are actually cysts that are formed in LAM, which can be destructive to the lung itself. Patients can also have abnormal growth on their fingernails and other parts of their bodies too. So these disorders are associated with tuberous sclerosis. Now, PEComas, I will say, that are rarely associated, rarely seen in patients who have tuberous sclerosis complex, but the appearance of the cells is very similar. And that prompted the speculation that there might be a common genetic mutation in PEComas as well. So let's talk a little bit more about PEComas. Go to the next slide. So these are rare tumors that can arise anywhere in the body. The most common sites for them to start are the uterus, the kidney, and the back of the belly, a space we call the retroperitoneum, usually next to the intestines. For reasons we don't yet understand, they're more common in women than in men. Of course, the uterus ones are obvious, but even the non-uterine PEComas are more commonly occur in women, about 4 times as many as likely in a woman than a man. Now, the vast majority of these tumors are benign tumors and don't come back after they've been removed. Many of those, most of those, don't make them to see Dr. Napolitano or myself as medical oncologists because they're benign tumors, and if a surgeon takes it out, they often are not referred to see us. It's difficult to fully characterize how common the benign tumors are, but a small subset of those can be malignant. And we use the same, we use different words to describe the same thing. So malignant also means cancerous or cancer, and both of those things mean the risk of spreading to other parts of the body. So Michelle described to us of unknown malignant potential her tumor was, meaning that they couldn't classify it as benign or malignant. The behavior told us that it spread and therefore it was malignant. But the pathologists try to characterize these things to say, does it look like it's not going to spread? Does it look like it's likely to spread? Or is it, we can't really tell. Malignant PEComa, so again, that very small subset of PEComas is the ultra rare sarcoma. This is less than 1 per million people per year. In the kidney, it's often called epithelioid angiomyolipoma. So often people will be told they have this. That's exactly the same as a malignant PEComa of the kidney. It's confusing, but it's different than an angiomyolipoma of the kidney, which is a benign tumor. So the epithelioid angiomyolipoma is the one that is a malignant PEComa. And to make it even more confusing, an epithelioid angiomyolipoma of the liver is not necessarily cancerous. So the pathologists are driving us all nuts, but this is the way it works. And so we prefer the term malignant PEComa for instead of epithelioid angiomyolipoma to help reduce confusion about the diagnoses. The different pathologists have described different features that may suggest that it's a malignant tumor. And also other colleagues have come up with risk classification scoring systems. It's not clear how well these work, and everyone has their local pathologist who they think does the best job in diagnosing these. But these are some of the key features, though, that are present. Necrosis is spontaneous death of some of the tumor cells. They can see that under the microscope. That would be a higher risk for being malignant. If there are a lot of mitoses or dividing cells under the microscope, that can be something that portends a higher risk of malignancy. If there's a lot of variability in the shapes of the size, we call that pleomorphism. That's also unusual, as well as the nuclei, if they have a funny shape to them. Those are some of the key features of malignancy. Even in malignant PEComas, though, we don't quite understand the risk of spreading. So for some types of sarcomas, we know that if it's malignant, it's at a very high risk of 80% risk of spreading to other parts of the body. There's some other types of sarcomas where even though it's malignant, there's a 5% chance of it spreading. We don't know quite where PEComa falls in that spectrum. My personal experience is that it's less than half of malignant PEComa spread, but it's hard to really get a firm understanding of that risk of metastases. And the other important thing is that they are often misdiagnosed. I'd say the most common misdiagnosis is they're called a leiomyosarcoma. This is another type of sarcoma. It often arises in the uterus. It can look a lot like a uterine fibroid, as Michelle described. This also expresses the smooth muscle markers, but does not usually express the melanocytic markers. And pathologists, this is where it's really important to have an expert pathologist review the slide so they can help discriminate between these two, because we do treat them differently now. Melanoma, which is a malignancy of those pigment-producing cells, occasionally is misdiagnosed as a PEComa or vice versa, again, because of the expression of melanocytic markers. And there's some other types of tumors that also can be misdiagnosed, but may actually be PEComas. I think pathologists are getting much better across the world in diagnosing this because of a greater recognition of this as an entity and what sort of tests are needed to help diagnose it. Go to the next slide, please. So I mentioned the mTOR pathway. So normally mTOR will drive different processes in the cells to help them get bigger and grow, to help them survive and not die, and to help them make new cells or proliferate. It's a very tightly regulated pathway. And part of that regulation is through this complex of the proteins made by TSC1 and TSC2. They normally turn down or turn off that mTOR signaling pathway. Go to the next slide, please. If you have a mutation in TSC1 or in TSC2, that complex falls apart. And then mTOR is hyperactivated, and it drives more cell growth, survival, and proliferation than should be happening in the cell. And that leads to the cells accumulating and forming the tumor. And it could be either from TSC2 mutations, I'm showing on the left, or TSC1 mutations, I'm showing on the right. Go to the next slide. And Dr. Napolitano will talk about this in more detail, but the mTOR inhibitors are drugs that can block mTOR activity even if TSC1 or TSC2 is not present. And that helps turn back down those processes back to the normal state. So that's the basis of many of our treatments for PEComa today. Go to the next slide. And just as this is my last slide, which is we see different types of mutations in malignant PEComas. And on the left, those are some of the more common mutations that we see that we think drive the tumors to form in the first place. TSC2 and TSC1 are by far the most common. TSC2 is up towards about half of PEComas. TSC1 maybe in the order of 20%. Those are the most common. TFE3, which is a completely different type of protein, it's one we call a transcription factor. It binds to DNA and turns on expression of other genes, is inappropriately expressed in a small subset of patients with malignant PEComa. And then really, really rare, but we occasionally see these are alterations in a gene called folliculin. That's often associated with a completely different syndrome called Birt-Hogg-Dubé syndrome, or mutations in BRCA2 or occasionally BRCA1, the ones that we commonly think about in breast and ovarian cancer. We have seen a few patients with this, with malignant PEComa. So you have one of those, and those are what we call driver mutations. They make the tumors form. Then there's a whole bunch of other mutations that can also occur. The ones that we see most commonly are mutations in these genes, RB, P53, and ATRX. RB and P53 are really critical proteins for regulating how cells grow and how they survive. They're commonly mutated in many different types of cancers, but we also see them commonly mutated in PEComas. And I would say that those three genes on the right are also commonly mutated in leiomyosarcoma. So none of these genetic tests really tells us is it a PEComa or a leiomyosarcoma, but these are some of the features that we tend to see in PEComas in particular. So that's the background on PEComa. I'll turn it over to Dr. Napolitano.
Thank you so much. That was a great, great background. And we will hear from Dr. Napolitano now.
Thank you very much for this wonderful opportunity, and good morning, everyone. Yeah, if we can, let me see. Do I have control, Christy? Or...
You should now.
Okay, so just moving on from what Dr. Wagner kindly explained, we do have a bit of a hard time defining what is a benign PEComa or a malignant PEComa, and oftentimes this is something that unfortunately we learn just by the clinical history of the patients rather than by the features that our pathologists describe. But the idea is that more likely than not, there is some sort of it's not like a proper dichotomy. We don't have either PEComas who are entirely benign or entirely malignant, but there is a spectrum, and each case will fall within this spectrum and will have an individual risk of relapsing or not relapsing. Of course, there are two extremes in this spectrum. So there are some PEComas that do not have any of those risk features that we know, and therefore the risk of recurrence is extremely low, whereas there are other cases where we have all of those risk characteristics, and in that case the risk of recurrence or of presenting as a metastatic disease, because this can also happen, is higher. So in terms of discussing the treatment options, of course, I split in localized setting and advanced setting. Practices can be quite different across different countries. I work in the UK, so that's an initial caveat. But they also sometimes differ within the same country, depending on the level of expertise of the physician and how familiar they are with this disease. I'll talk a little bit more about some global collaborative effort that we're setting up, and Dr. Wagner is one of the leaders of this group. We're trying to harmonize our practice to treat sarcomas in general and PEComa as well. And that's why, global studies are really, really needed. So moving on to a little bit more details. In the localized setting, slides are challenging. we of course, surgery is the most important treatment. This is true for all most sarcomas and for PEComa as well. And in those quote unquote benign PEComa, surgery is virtually curative in almost all of them. So these are those patients that have a relatively small disease with none of those pathological features that we've learned over time are associated with a risk of recurrence. Again, the pathology should be reviewed in an expert center, and this is really, really crucial. As Dr. Wagner mentioned, also in those cases where we have so-called malignant PEComas, so PEComas that show some of those high-risk features, surgery, when the disease is localized, is curative for most patients. The risk of recurrence is not clear, and it varies between 30 to 50%. That's the rough estimate, but we are collecting data to try to also understand a little bit more the natural history of the disease. And as we mentioned, there are some risk characteristics. We don't really understand all of them, besides the one that we know from the pathology. There are other clinical factors that have been associated to a higher risk of relapse. Older patients seem to have a higher risk of relapse, whether that is because they are less likely to receive a very aggressive surgery, or whether it's because the immune system may be not working as well as compared to a younger patient, is currently unknown. It's just an observation. And similarly, we know that patients with large abdominal disease in the retroperitoneum, which is the space behind, next to the bowels that we mentioned before, seem to have a higher risk of relapse. But again, these are just clinical observation. At this stage, it's unclear whether there is something in the biology of the disease or in the biology of the patient that really makes a difference. In terms of other local treatments, which you might have heard or discussed with your physician, radiation therapy is one of these. Sometimes ablation is also mentioned as a potential treatment. And this is just to basically give a really broad summary. Radiation therapy and other non-surgical local therapies are usually not considered routinely for all patients. Of course, all sarcoma patients should be managed by sarcoma experts, and we really work within multidisciplinary teams. So the decisions very rarely are made by a single doctor. They are made by a group of people really expert in the disease, which always includes a surgeon, a medical oncologist, an expert clinical oncologist, the pathologist, and other members of the team. So in very selected cases, after discussion in our multidisciplinary meetings, we sometimes consider localized treatments like radiotherapy or other treatments. And just to give you an example, for example, if surgery is performed and is not complete at the microscopic level, meaning that when the pathologist looks at the specimen and it looks like some of the PEComa cells are reaching the edge of what was resected. And if the surgeons tell us it's impossible for me to go back and perform another surgery, and maybe the patient is, more advanced in their age, so we are not very concerned about the risk of second malignancies, we can discuss the option of offering radiotherapy after the surgery to decrease the risk of a local recurrence. And similarly, in patients that have very few metastatic sites, we often discuss the option of surgical approach or ablation, but these are always decisions that need to happen within the context of a multidisciplinary meeting. And for more truly advanced cases where it's difficult to offer localized therapies, we briefly anticipated that the mainstay of the treatment is a class of drugs called mTOR inhibitors. And these are drugs that target the molecule that is downstream of TSC1 and TSC2, which are the genes mutated in PEComa. We can consider this to all effects and purposes a targeted therapy because the mTOR activation is the driver for most PEComa. And mTOR inhibitors are a small class of molecules which has high efficacy in this disease and relatively good tolerability. There are several different mTOR inhibitors. What they have in common is the fact that their name ends in Rollimus. And interestingly enough, they were first identified in 1975 on Easter Island. The name of the island in the local language is Rapa Nui, and the first compound is called rapamycin. And it's also known nowadays as sirolimus, and this name will come back shortly. Because of this association between the activation of the mTOR pathway, in the early years of in 2008, 2010, there were first case reports, a small case series of these drugs used to treat PEComa patients. The drugs were initially developed as immune modulator. They are used in patients who have transplant of other organs. So they were not really originally developed to be cancer drugs. And as it happens for most drugs that we use in sarcomas, and especially in ultra-rare sarcomas, repurposing an effective drug was really crucial. And this repurposing came from the observation of a molecular driver, which were the TSC mutations. So the first case series were in 2008, 2009. Very good results were reported. This disease was known to be relatively fully responsive to most of the available chemotherapy. So across the globe, most physicians started to use drugs belonging to this family in what we call a sort of an off-label, meaning that even though the drug was never formally approved, physicians across the globe saw approval to use this drug in PEComa patients because we knew that the drugs were effective, even though formally we didn't really have a large study testing the efficacy of this class of molecule. And things have recently changed, and Dr. Wagner is a leading author of this trial, the IMPACT clinical trial, which tested in PEComa patients in a proper formal clinical trial, a phase 2 single-arm clinical trial, nab-sirolimus, which is a modified version of sirolimus, which has a coating of albumin, which is a protein that is usually present in our blood. And what basically the modification of sirolimus with albumin changes the property of the distribution of the drug in our system, and that basically leads to more constant levels of the drug over time, and it has an impact on the tolerability and improves the tolerability of the treatment, maintaining the very high efficacy that we know belongs to this class of medication. I'm not showing any of the curves of the scientific results, but I thought it was important to, of course, to mention that this positive trial led to the FDA approval in 2021. Dr. Wagner recently also reported the long-term outcomes of these patients on nab-sirolimus in the clinical trial. And also at the Marsden, we've treated several patients with a compassionate use program, and the drug is being used across the globe with great success. Of course, the efficacy of the drug is really, really high for our standards, but we have to be conscious of the fact that this is not a miracle drug for all the patients. Significant tumor shrinkage is observed in approximately 40% of the patients. A relatively good proportion of patients has what we call a stable disease for a long time, meaning that the tumor doesn't shrink significantly, but it also doesn't grow significantly. What we know is that patients that achieve a very good shrinkage usually benefit from the treatment for a long time. And there have been several cases of patients whose response has lasted for 4 or 5 years. So we know that there is a subset of patients where the drug is exceptionally active. And there is a subset of patients where the drug can still work, but it may not be as good. So one of the questions is, why do some patients respond better than others? And there is a feeling that what the genetic mutation could be a contributing factor, with patients having one type of mutation being more sensitive to the drug compared to patients with other mutations. But for sure, there are other factors that we're still just starting to learn and to understand. So there is a lot of work that is being done to better clarify what are these mechanisms. And are there other therapies? Again, these are not standardized. The access to these therapies is widely different across the different countries. For some patients, especially for PEComas of the arising in the uterus, we know that sometimes they express estrogen and progesterone receptors. Hormonal therapies have been tested in some of these patients, oftentimes in association with mTOR inhibitors rather than on their own. And there have been some reports that adding hormonal therapy in patients with estrogen or progesterone receptor positive PEComas can restore a degree of sensitivity to mTOR inhibitors. When mTOR inhibitors fail, there are other class of drugs that can be used, but the efficacy of these other compounds is significantly lower compared to the mTOR inhibitors. Access may not be easy in many countries. For example, in the UK, we don't have access to anti-angiogenic drugs or immunotherapy for PEComa patients as of today. And chemotherapy, we know that PEComas is now one of the most sensitive subtypes, but recent retrospective data, so collection of data from all the centers, suggests that some chemotherapies, like one called gemcitabine, can help about 20–30% of the patients in controlling the disease for a period of time. Of course, again, these are ultra-rare sarcomas, and up until recently, every physician was working on the basis of their own experiences. We're only just now coming together at a global level to try to build up knowledge and standardize treatment. And this is a good introduction to this push platform. And I just wanted to mention to you, because globally we have created a consortium of clinicians and also researchers interested in ultra-rare sarcomas, including PEComa. And we've created this push platform, which is Pushing Ultra-Rare Sarcomas Towards Hope. And this is a global consortium whose goal is to collate data from all the expert centers that see patients with ultra-rare sarcomas. Right now, we are in a stage where we're mostly collecting data from patients that have already been treated in our institutions, but the ultimate goal is to facilitate international clinical trials also for patients who have ultra-rare sarcomas. And Dr. Wagner is leading the PEComa subgroup for the PUSH platform. And in terms of other research, I just wanted to briefly mention some of the work that we've done that has been funded by Sarcoma Foundation of America on PEComa. This is some of the work that we've done with proteomic analysis, meaning that we've taken samples of patients with PEComa, and we have analyzed all the proteins that those PEComa express. Proteins are the building blocks of the cell. And the reason why we do this analysis to try to identify new targets and cluster of proteins who are expressed that might predict which patients are more likely to benefit from the treatment or less likely to benefit from a treatment. As you can see, the number of patients from this research is fairly small, because even though we are an expert center, again, these are ultra-rare sarcomas. So in the future, what we want to do is research similar to this, where we do analysis on the tissues with more advanced technique, single cell technique, to really understand better the biology of the disease, but on a global scale. So this is what we're trying to do, and I think that this could be a good way to start the discussion. In terms of future directions, where I think the research is leading is that we know that some mutations may be more responsive to some treatments rather than others. So one approach is definitely going to be to try to develop a mutation-driven therapeutic approach where we treat patients with mutations in one gene or in different gene differently. The combination of mTOR inhibitors with other drug to increase the number of responders and increase the duration of response is definitely something of interest. And as Dr. Wagner explained, PEComa is one of the few sarcoma subtypes that expresses melanocytic markers. And in melanoma, there is a lot of research in immunotherapy specific target some of these melanoma molecules. And we hope to be able to borrow some of these drugs and to repurpose some of these drugs to bring novel treatments in PEComa as well. And I'm going to finish it here. Thank you very much.
Thank you so very much. That was a wonderful introduction and overview of the current treatment strategies. You actually led me right into my first question for you, and kind of gave me a little bit of a teaser of what your answer might be. But both of you mentioned the importance of the mTOR signaling pathway and the mTOR inhibitors for the majority of PEComa patients, and that there are some treatment options that are available for the patients that fail. But there's also, it seems to be a significant portion, a portion of patients who are not mTOR dependent, or that they may have a different genetic driver. Is there a standard for patients to be tested to find out what their tumor driver is? And is there a strategy for moving forward that patients should consider doing this and look for a specific type of treatment?
So let me get started on what we do in my center and across the UK, because again, this is a case where I think that the practice in reference center might be different compared to community hospitals. So the reason why we stress the role of having samples and reviewed by an expert pathologist and also patients in an expert center does include testing for the molecular analysis. So in our hospital, when the pathologist looks at the sample, if they are confident that there is a good chance that this is indeed a PEComa, they run a panel to identify whether there are these mutations and which mutation there is. And this is, as of today, mostly a diagnostic role, meaning they're identifying the presence of a TSC1 or 2 mutation or of the translocation, TFE3 translocation, further confirms that this is a PEComa without any doubt. And that can be helpful in those cases where the diagnosis might be a little bit more difficult based on how the tissue, the tumor, looks under the microscope alone. So in our center, those tests are routinely performed when PEComa is one of the potential diagnoses. They're not used to guide treatment as of yet. So if the diagnosis is PEComa, we tend to offer an mTOR inhibitor regardless of the mutational status. We think that there might be patients where the mTOR pathway is the driver, and patients where mTOR pathway is still active, but it may not be the only driver. But most PEComa will have an activation of mTOR, even if they're not driven by one of the 2 classical mutations. So given the efficacy and good tolerability of these drugs, we still favor offering these drugs to all our patients, regardless of the mutational status as of today.
So I agree, especially with the latter part of that, which is mTOR inhibitors have become the standard first-line treatment for metastatic PEComa. And we're still trying to understand how well it works for the non-TSC1, TSC2 mutant tumors. In the MPEC study, we saw a response in a patient who didn't have an identified mutation. We saw essentially every patient who had a TSC2 mutant tumor had a response. In the actual data of the study, you'll see 8 of 9, but that's because one was not what we call a confirmed response, which means needing a second scan after that showing ongoing response, the patient had stopped treatment. But really all the patients with TSC2 mutant tumors responded, and 1 of 5 patients with TSC1 mutant tumors responded. And we don't know if that means it's 20%, or is it the sample size so small that it's much lower or much higher if we had more patients. So we just don't know. And I think these are exactly what Dr. Napolitano was saying about, as a global community, trying to collect that information and have a better understanding, which is much more powerful than any of us can do at an individual institution. We don't, this might be a peculiarity of our institution. Our pathologists don't routinely send for molecular diagnostics for this disorder, for this type of tumor. We try to send it on many patients. There's some barriers and there are different ways of doing it. And I think we see this across different countries too, that some countries it's very difficult to send molecular testing. In other countries, it's pretty routine. In the United States, it often has more to do with whether or not insurance will cover it, because it can be quite expensive for patients. Since it doesn't necessarily guide our treatment, we don't use it as a treatment decision, but it can help reinforce a diagnosis. I just want to make sure it's clear, though, that there are other tumors, including leiomyosarcoma, that can have TSC2 mutations. So a mutation alone does not define a PEComa. And that's, again, back to that point that expert pathology review is needed. It's not just sending it off to a vendor who does genomic testing and let them come back with a diagnosis. You need an expert pathologist to review the material. I think the other things that, getting the sequencing is super helpful from a research perspective and trying to understand the full spectrum of mutations that we see. And we all experience sometimes these patients that do surprise us with the tumor analysis. For example, a few patients where we've seen these BRCA mutations and have been able to successfully treat patients with a totally different class of drugs called PARP inhibitors after they've had progression on an mTOR inhibitor. But again, those are really, really small subsets of patients. But we have a lot more to learn. I think that's the clear thing. We also have very little understanding of why a tumor that initially responds stops responding and starts to grow. And we try to understand it. For many other drugs like these, we can find very specific mutations that prevent that drug from working. We've not seen that in PEComas. We don't have a good idea of why secondary resistance occurs. But that's really important to understand so that we can try to design the next drug or a better drug that might have more durable activity. I just will keep saying we have a lot to learn about this, but being an ultra rare disease, it's difficult for us to do it individually, and we really need global collaboration in this.
Thank you. Michelle, I actually also would like to hear your perspective on this as a patient and as really your own advocate in this context, as the one experiencing the relative tolerability and as somebody who has been through this process. How do you feel that your role as a patient falls in this?
So throughout after my diagnosis, I really wanted people to know about PEComa. Right now, I am in a good place with my treatment. I am using the mTOR inhibitor, nab-sirolimus. I know we don't want patient specifics. Every case is different. I was able to do some genetic testing, which was quite interesting. And some of my markers are not typical, which is another interesting case per se. But in order for me as a patient to feel a little more hopeful about my case. You know, I've read a lot of research articles. I'm trying to keep up with the current situation of PEComa, and I have been an advocate as well. It kind of makes me able to take, you know, the power back as a patient. You know, I can't just sit and do nothing, you know, I have my treatment, and generally, you know, I follow doctor's orders, but I try to pretend that this doesn't exist in some forms. But I am a big advocate of PEComa. I'm trying to get everybody to know the word. You know, as a subtype that's really rare, people don't know about it. You know, I've gone to different doctor's office, medical institutions, and they're like, you know, what is a PEComa? But I've worked with, you know, Sarcoma Foundation, the Race to Cure in Boston. I actually helped get PEComa subtype on your website, which was great. I'm just keeping with the flow. I did attend a cancer walk in Worcester, Mass, for UMass Chan Hospital. It's a teaching hospital, which is great. And I distributed some Sarcoma Foundation materials so that people will know more about PEComa. And I'm always up for, you know, learning more research and being able to participate in anything new. Trying to think what else. Yeah, certainly I'd like to be more involved in any new programs. And if any of the doctors need any more information, case specific, I'm always happy to volunteer that information.
Thanks for sharing that, Michelle. We have a question from our participants. And the question is, in cases where PEComas are located in more unusual or rare sites, does the atypical location influence how a clinician might assess the malignant potential or adjust the recommended surveillance strategy?
Again, I don't think that we have a standardized answer, and we go back to the lack of data to answer this question. I think that the location of the tumor, to the best of our knowledge, is not necessarily a factor that contributes to the specific risk of malignancy per se. What the location of the tumor might have an influence on is the how much time it takes for the tumor to be diagnosed, just because symptoms may appear later in life, and tumors might be bigger at the time of presentation, or the tumor might have more time to you know, develop in secondary mutations and to spread to other organs. So I think that the location is definitely one of the factors, but as of today, I don't think that we can conclusively say that location influences the biology. I would say that location may influence the time to symptoms and therefore the time to diagnosis, and that can have, of course, consequences. In terms of surveillance strategies, again, I don't think that we have an answer. We do not particularly tailor our surveillance strategy based on the site. Of course, if the tumor is in a location which is more difficult to self-assess, for example, intra-abdominally or also in a pelvic site, you do need to have radiologic imaging to at the same time assess for the risk of local recurrence and distant disease as well. If you have a disease that is localized on a limb, for example, sometimes we tend to do, in any case, radiologic surveillance of the whole body regularly, but in cases which are felt to be not very aggressive or more on the benign spectrum, one might avoid scanning very often the chest or the abdomen and pelvis. So surveillance strategies, I think, that might be different based on the perceived risk of relapse as opposed to location per se. But again, location is a factor. At least this is how we try to put these aspects together.
Sorry, I couldn't find my mute button there for a second. Dr. Wagner, did you want to add anything, or should I add another question?
I
Okay.
think that was better than I could say. So
Okay. So I have one last question here for you all. Both of you mentioned, actually, I think Dr. Wagner, it might have been you that brought it up, but that patients with benign PEComas, or presumably benign PEComas, often are never seen in a clinic such as yours or sent to a sarcoma center. And the question is there a point at which you would recommend patients who are in this circumstance, or presumably in this circumstance, seek a second opinion and find out, or get evaluated to find out if they really are truly in a benign situation, or if they are more predisposed to malignancy? Is it safe or fair for these patients to not ever be seen at a sarcoma patient, even if their PEComa was deemed to be benign?
It's a challenging question, just because we don't see a lot of patients in that situation, so it's hard to know what their future outcomes would look like. I mean, I think we're all happy to see anybody. I suspect if a patient, I'm pretty sure of this, in fact, that when a patient comes to see me and the diagnosis of benign PEComa, being an oncologist, I can't do anything but continue to do imaging like I would, not quite as frequently, but I'd probably test more than I would if the patient, than I would otherwise recommend, basically, just because the patient has made their way to my clinic. So sometimes then I just, out of caution, I'll do some surveillance imaging. Is that a good thing or bad thing? I don't know. I haven't seen one come back yet, like the disease come back when it's truly benign. I do think, again, I'll keep reiterating this, it's just as Dr. Napolitano did, which is it's important for that pathology to be reviewed by an expert center. So I think that's a critical step, which is if a patient receives a diagnosis in a more community setting, make sure it gets sent out for just confirmatory review. And if that requires going to another center for a full consultation, then that's great. But sometimes the pathologists are willing to send it out anyway, just for another review. I think, and then the other piece of it is whether there's any suggestion of an underlying genetic syndrome that might predispose someone to PEComas and to other tumor types. And that's going to be very individualized. It depends on the family history and other characteristics of that patient. So again, if there's uncertainty, it's potentially worth discussing it with a medical oncologist or a geneticist to see if there might be a risk for tumors.
That's really helpful. Yeah, the idea that having the pathology reviewed by a sarcoma center, even if the human being or the patient doesn't make their way entirely to the sarcoma center, is really helpful information, especially for patients who may not have the ability to, or financial ability or physical ability to travel. That's really helpful. Thank you. Okay.
You're on mute, Christy.
Sorry about that. Thank you. That was very helpful information. So I'm sorry if I missed anything there. With that, we will need to wrap up our session. Thank you all for taking the time to be with us today and sharing your expertise and experiences. We appreciate all that you do for the sarcoma community. And thank you also to our sponsor for today's discussion, Aadi Bioscience. As a reminder, today's session was recorded and a link will be posted to SFA's website within the next few days, as well as emailed out to all participants. It will be on our website at curesarcoma.org. This now concludes the discussion. Thank you all, and we will see you next time.